on the kind of run through of that in a second of what we're doing. There you go. So you should have got a notification to say we're recording the session. That will be on our YouTube channel as well later on. So we will hopefully have that up and running later today. So bear with me while I'm still inviting people into the session. There's also been a technical problem this morning, which is an issue. So I can note I haven't got an update on the slide, which should be there. So hopefully this will be the latest version. If not, you'll give me some. I'll give you some verbal updates as we go for the latest information we need. So I think we probably need to get going. Like I say, I'll be a bit distracted as we start, as people come in, but hopefully we'll be fine. We should have started recording, so that should all be good. And like I say, this session is provided by Drink Drug Hub, so we'll do some introductions to begin with. My name's Matt. I am, hang on, we're not getting anyone coming in here. There we go. So there we go. I'm the strategic lead for North Yorkshire Horizons. One of my main roles is running Drink Drug Hub, this website, drinkdrughub.co.uk. Anyone can come and visit that site. So that's where we've got free training, free resources. As you can see here, we've got videos, guides, tools, web pages, all sorts of information that's available. We check it all to make sure it's accurate, and then we post it all online so that anyone can visit at any time and check those out. We also offer lots of free training as well, so we've got all these courses available. How's this for multitasking, by the way? I'm admitting lots of people and presenting at the same time. So we've got loads of courses available here. I would really flag up, actually, we've got a new one out at the moment about caring for someone who drinks or uses drugs. I would really welcome people to come and check that out. People really keen to come and understand drugs. As you can see, this is a really popular session today. How do we prevent harm for people who use drugs? How do people take drugs more safely? But a really good way we can prevent harm is better support families, carers, help them better understand what's going on for their loved ones and how to support them. So do come and check that out. It's on for 4 sessions. It starts tomorrow and it's available to book now. So presenting with me today is Craig, and Craig actually presents, so I do Drink Drug Hub training. Craig chairs the Emerging Drug Trends meeting, and that's how this session came about today. It's, well, Craig, can you introduce yourself and tell us what you do in Emerging Drug Trends meeting?
Yeah, morning everybody. Craig Bosworth, I'm the strategic harm reduction lead, so working within the public health team for North Yorkshire Council. So yeah, Matt's right, I chair the Emerging Drug Trends meeting, which happens every month. It's a partnership meeting, so has a membership quite wide really in terms of safeguarding young people, services, police, drug services. And we all come there really just to kind of share intelligence and trends that we're seeing within the work that we do with people. And that kind of information then obviously feeds into lots of different channels, this being one of them, but also into Drink Drug Hub and the kind of resources that we put on there. It also feeds into various different meetings that we have with police and colleagues that are looking to kind of map that risk in North Yorkshire in terms of what is in our county and what could be causing harm. So Perfect. Good to be here.
Brilliant. Thanks, Craig. So from that, we've blended these two things together to create Drugs in North Yorkshire as a regular workshop. We run every 3 months and we choose a topic that we're seeing prevalent within North Yorkshire to cover. So we're getting everyone up to speed with what we're seeing and what's worth knowing about. And for this session today, we're looking at prescribed medications. Now, it's worth noting before we begin that when we're talking about a lot of the risks in the session, we're talking about illicit use of these medications. A lot of people will be prescribed these medications and they'll be able to take them perfectly safely. So please don't worry about medications you may be prescribed as a consequence of attending this session. If you do have concerns, see your prescriber. But a lot of the risks we're talking about is about when people use them illicitly. And this is what we'll go through. We'll be done by 11 o'clock. We're going to look at how prescribed medications can be harmful, again, when taken illicitly. We'll look in particular at benzos, Zopiclone and Pregabalin and the trends in use that we're seeing. We'll look at counterfeit products and the illicit market, including online pharmacies. And then Craig will talk us through what we're seeing in North Yorkshire. And then finally, we'll look at getting help and staying safe. Now, you may be wondering why we're looking at prescribed medications. And a little note here to say, when we're talking about prescribed medications, we're talking about any medication legitimately obtained from a healthcare professional. So it could be a pharmacist, it could be you prescribed this on discharge from hospital, for instance. But it's ultimately any medication that someone legitimately obtains is what we talk about prescribed medications. And obviously we're looking at what happens when people use them when they haven't got a prescription. Now, I did ask Craig this question because Craig suggested this topic for today, and I said, well, why prescribe medications? And Craig gave me this answer. This is email back, just basically saying we're seeing lots of contaminated drugs. It's the most contaminated drug market in the UK when we look at benzodiazepines in particular. We've seen fast parcels heading to North Yorkshire containing large quantities of pregabalin drugs from India. And we've seen large numbers of different benzos in North Yorkshire, and he lists a lot of them there. I'm not going to try and say those. Craig will be able to say them for us. That's why we've got Craig here, because he's the expert around this. So it's a big topic in North Yorkshire. And just to emphasise that we have already looked at drugs like ketamine, the traditional street drugs we might have seen. And when we looked at ketamine, we looked at some of the media reporting around it, the big panic we've got around the increase in young people using. It's being talked about as a crisis and as a pandemic. But to put that into context, in 2024, 70 people died having used ketamine. But we can compare that to some of the drugs we're looking at today, and you can see the death rates here are actually quite a lot higher for drugs like diazepam, pregabalin, Zopiclone, are all actually significantly higher than ketamine. Now, I should say death is just one measure of drug harms. There's lots of other nuances here to bear in mind. But we need to think about how is this happening? And it's happening because maybe people don't take their medication as prescribed, so they're increasing their dosage or their frequency of use. They might be mixing it with other drugs. They might take someone else's prescribed medication. They may buy it illicitly from a dealer, or they might be buying it online from an illegal pharmacy. And it's great to see someone's put something in the chat there. Thanks for that. Craig's answering that question as well. So if you do have questions, if you put in the chat, I'm sure Craig can manage those, and we'll go through questions at the end as well. So that's how this harm is happening. A big question is who is being harmed, and this is where it's quite different to street drugs. So for instance, you would look at ketamine. When we looked at ketamine, we talked a lot about young people using ketamine being harmed by ketamine, and when we looked at cocaine last time, we looked at middle-aged people, middle-class people in particular, males in particular being harmed. Like we could define specific groups of people being harmed by these drugs. But when you look at prescribed medications, it gets a lot more nuanced. Like there's lots of different age ranges and people being harmed here. We've got children who are taking medicines from medicine cabinets at home. We have teenagers trying to cope with the stress of alcohol, college and university and using for that. We've got young adults who are recreationally using prescribed medications on nights out. We've got victims of spiking. These are people who haven't consented to take this drug but have it administered to them in a drink. Often that's a benzo. It's often related to Rohypnol. No, that's a bit of a misnomer, but Rohypnol is actually a benzo. We've got patients who are prescribed by their doctors with no illicit drug taking history or background. And then we've got people with long-standing addictions who are maybe mixing prescribed medications with other drugs. I think Craig will tell us a lot about that today. And then finally, with older people who have increasing health needs and greater reliance on medications as a result, and also can end up becoming dependent to these drugs. So this is actually a lot about different people using these drugs, but it's also about a lot of different medications. And we should mention that actually, if we looked at painkillers, for instance, we'd be here forever because there's so many painkillers to look at. So to keep things simple, we will today just concentrate on benzodiazepines, pregabalin, Zopiclone, and in particular, benzos will be the big category we'll look at because that's where we see quite a lot of use and potential harm. So to give you a bit of a history around benzodiazepines, these are drugs that can help people feel less anxious. It can help calm them. It can also help people go to sleep. A bit of a history lesson here is to say that traditionally, years ago, the drug that we would turn to for managing this would have been alcohol. In the 1800s, we actually found bromides. Now, I don't know much about bromides, and you don't need to know much about them for today, other than they serve much the same purpose. But in the 1900s, we came up with barbiturates. Now, these were really good in terms of helping people feel calmer, more sedated, helping people sleep, but they had loads of really negative side effects. So headaches, confusion, disorientation, risks of overdose. One of the real big concerns was how dangerous barbiturates could be. And quite a few notable celebrities have died through barbiturate use. So Marilyn Monroe, Jimi Hendrix, Jim Morrison all died having taken barbiturates. So it was a bit of relief when benzodiazepines came around in the 1960s. These also help treat anxiety, sleep disorders, but they had far fewer side effects and they were much safer to prescribe, so they became really widely prescribed quite quickly. So when we're talking about benzodiazepines, we're actually talking about a group of drugs. And the first of these that actually came to market was chlordiazepoxide, called Librium. That's the trade name. That came in 1960. It was noticed that it tranquilized lab animals, but it had no apparent side effects. So this seemed to be like a perfect solution for a lot of problems people had. After that, in 1963, we got Valium, or often, diazepam. This worked faster, it lasts longer, and it quickly gained popularity, as we'll see in a second. And then in the late 1960s, we got alprazolam, also known as Xanax. That's more potent and it wears off faster. Now, it's really important to point out here, we actually now have somewhere between 50 to 70 different benzodiazepine drugs available. The main differences are between one and the other is how quickly they work, how potent it is, and how long the effects last. So this is really critical information for anyone who might be taking a benzodiazepine to know how one actually is different to another. So there are comparison charts that you can find telling you what the differences are. So for instance, if you are taking Xanax, you need a 20th of the dosage that you would have diazepam for the equivalent effect. So it's really important to know what's the actual dosage of the one you're using, how fast might it work, and how long might it last. Now, benzodiazepines also fall into two categories. So we've got anxiolytics, which treat anxiety, and hypnotics that aid sleep. And when we're talking about drugs that aid sleep, that brings in our Z drugs. So Zopiclone would be one of these. These are chemically different to benzodiazepines, but they fulfill a very similar role. So you'll often find them talked about in the same kind of breath, really, in research. They're often referred to as sleeping pills. So we also see people using these drugs as well in much the same way they do with benzos. But to go back to benzodiazepines, as I say, we discovered them in the 1960s. We ended up with quite a few quite quickly, and they quickly became really popular, particularly diazepam, like I say, also known as Valium. The Rolling Stones wrote a song called Mother's Little Helper, which is all about this, about mothers at home using these to try and feel a little bit better. We suddenly had this group of drugs that could help people feel less anxious, it could help people get to sleep, and it seemed to have very few risks and side effects. By 1977, benzodiazepines were the most widely prescribed drugs in the world, and diazepam was the most widely prescribed drug of all in America. And this seemed to be a really good category of drugs that seemed to be really helping a lot of people. But it was in the 1980s where we started to get some real significant concerns about benzos. So there's big media coverage then about actually people are becoming dependent to these drugs. Now, they're really only meant to be prescribed in the short term for about 2 to 4 weeks time. And that gives people the benefits they're after, easing nerves, helping people sleep, but then it's not meant to become a long-term prescription. But they found in the 1980s, doctors were often prescribing these longer term. People were building up a tolerance, which meant that actually it was having less effect. They were needing to increase their dosage. And then they were experiencing withdrawal if they tried to stop. So in 2001, Panorama actually ran a program about this, saying they estimate about 1 million people in the UK were actually addicted to their prescribed medications of benzos. Now, Esther Ransom was on that show. There she is. She's appearing in 2001, and she appeared as a guest because she had actually covered the same topic in 1984 on her program called This Is Life, or That's Life. And she said in the program, when they covered this in 1984, it received the largest number of letters from viewers when they covered any other health issue that they'd ever covered. So it was hugely kind of responded to by the audience. So we'd known it was a problem in 1984 and in 2001, and it still is today, that people may be on to prescribe benzodiazepines and then find that actually they go into withdrawal when they stop taking them. Now, initially what a patient might experience is something called a rebound, which is they stop taking the benzodiazepines and the symptoms that they initially were prescribed for just return, but sometimes much worse. And that kind of makes them feel like they need to return to using again to try and manage those symptoms. Now, longer term, and this is where the serious kind of withdrawals start to become an issue, we have many more concerns around what happens if we try and stop them. And actually, the withdrawal symptoms that we know are associated with benzos have a lot in common with withdrawals from alcohol use. So anyone who's familiar with that can see these kind of issues here. So we've got things like anxiety, we've got nausea, we've got sleeplessness, we've got depression and really quite dark thoughts. In extreme cases, we've got seizures, convulsions, and these can be fatal. So this can be a really difficult place to be in when you're taking a medication, and when you stop, you start to feel these things. And this is our first category of people who become dependent on these drugs. And this is sometimes referred to as involuntary dependence. They're people who have been legitimately prescribed to begin with for a presenting need. They tend not to have a history of drug addiction. They tend to maintain their supply through ongoing prescribing, and they tend not to mix with other drugs. But the problem is that once they're dependent, what happens if then the prescription ceases? And this may force them into the illicit market to then seek other drugs that way, or to find the same drug illicitly. You can see there was a book published in 1994 covering this called The Accidental Addict, which is really sort of a point of reference to say we've known about this group of people for a while, and 2001 is estimated this might be 1 million people in this category. But it isn't just these people who are affected by prescribed medications. We also have what we call voluntary dependence, or researchers sometimes call it voluntary dependence. And I think we should acknowledge that's problematic language, because who volunteers to be dependent on drugs? But what they're referring to is a second group of people who haven't actually been prescribed this medication at all, but have sought out this drug for its psychoactive properties to begin with. So from day one, they're seeking it illicitly. These people tend to get it from multiple sources, so from friends, dealers, websites, and they're also more likely to mix it with other drugs. They don't exclusively do that. They do just use this drug by itself, but they are more likely to mix compared to the first group. And we can split this group into two further subgroups. So we have young people potentially using in this way, as outlined by the Benzo Research Project. And we also have older, more experienced people who use drugs, mixing it with generally opioid drugs like heroin. So two quite distinct groups. Now, the first group were researched quite extensively by the Benzo Research Project, which was published in 2022. And that looked at young people aged 18 to 25 and their illicit benzodiazepine use. And this was like an online survey they could complete. What they found out from the responses from this was that young people were using benzos to cope with stress of school and university. In fact, often these were triggers to start using, and often this was as low as the age of 15 to 18 for most of these participants. They were more likely to be mixing with alcohol for a cheaper night out, but again, it was about 50-50. A lot of them were just using the drugs by themselves, but often a lot were mixing with alcohol. Some of them were using to manage the come downs from other stimulants. So they might have a night out, particularly using things like cocaine, or even just using energy drinks, and then using a benzo to try and sedate themselves afterwards. Some were using at festivals to enhance their recreational experiences, but some were just trying to cope with daily life. It wasn't recreational use. It was just, I'm not really coping very well. Interestingly, with this group of young people in particular, they didn't really have a great understanding about the risks. So it came to a surprise to some of them that it's risky to mix with alcohol, and say, well, I've been doing that for quite a while. I didn't know that was risky. We have our second group there. These are our more experienced people using drugs, typically heroin or on methadone programs. They're also mixing with benzodiazepines and Z drugs. And there's another piece of research, quite recent from 20 to 25, exploring this. And they found that they were mixing to enhance the effect of heroin, to help them sleep, to feel better when they wake up. They were often splitting their dose. So they were using some benzos to help get to sleep, and then they had some next to them in the morning when they woke up to feel better when they woke. Some were managing withdrawal, but again, a lot were trying to cope with daily life. Now, this group did have better awareness of risks. So you can see a quote at the bottom here. There's someone saying, well, I don't really know what's in the drugs that I'm buying. Like, they're not pretending that these are genuine products. And that's why I'm really kind of mindful about that, because at the time they did this research, they said 3 people a day were dying in Glasgow is what this person understood. Now, to go back to the Benzo Research Project, there's some really interesting takeaways to take from this. And this is available online. If you want it, I can send you the information to have a look through it. They found that the young people involved in this research, they said, well, actually, first of all, we are seeing more young people using in this way. So the proportion of young people in treatment for use of benzos has increased 5-fold from 2017 to 2021. And Craig can probably tell us a bit more about the trends we're seeing when I hand over to him. The age range of first use was generally somewhere between 15 to 18 years old. And again, exams, university-related stress was often a significant factor in starting use. Within these groups where there was use, that use was quite common. Now, most young people are not using in this way, But if they are using, they're often in connection with other young people using, and it's kind of normalized to use benzos and even celebrated or encouraged. They talked about the affordability of benzos being a big attraction, like it was actually quite affordable to do this. And often, again, they were using this as a way to reduce the cost of a night out. So you didn't need as much alcohol if you're taking some benzos, you kind of get a bigger effect from it. So it brought down the cost. But again, they weren't really clear on the risks of doing this. Some had started on prescriptions from GP, but most had actually sought an illicit supply to begin with. Now, this comes with risks, and I should point out here that although I'm going to go through the risks here, a lot of the young people also used benzos without suffering serious harm. I think it is important to point that out, because sometimes if we just look at risks, we can then imply from that, oh, brilliant, Ash has put the link into the chat there for this research. If we don't talk about the fact that a lot of people use these drugs without really suffering serious harm, it can imply that people are being making really unwise or, decisions that don't make sense, and we can judge them for it. But actually, it kind of does make sense if a lot of people are using without getting harm, that why you might try and use as well. So I think it is important to sort of reflect that back here, that this doesn't make people bad or unwise or less clever to be doing this, not at all. So there's plenty of reason why they might try them, but then experience some of these risks without expecting it. So blackouts and memory loss were quite common. That means I just don't remember what I was doing, and this is really dangerous because some people were potentially sleeping with people or engaging in other activities and then not remembering doing that. One person couldn't remember sitting her final exam. We also had delusions of sobriety. So people had taken it and then they thought they were more sober than they were. So they were trying to take more benzos or trying to drink more. And importantly, it said in the research, they were being restrained by friends and partners and girlfriends and boyfriends to stop them from doing this. And we'll come back to this at the end. It's really important people look out for each other because of this, because your own decision making can be really severely impaired. We can see that in changes in mood and behavior. We had people behaving quite recklessly, including drug driving, and some people crashed their cars. There were fights, some people were stealing. Many experienced relationships and friendships ending as a result, and that's something we don't always talk about. We just talk about the drug-related harm in the immediate sense, but there's all this secondary harm that happens for people as well and can really damage their life in quite profound ways. We have the after effects of use. People had skipped school, slept through school, performed poorly at school, and also scored worse grades. Someone was expelled from university and another person was sacked from work because of this. So again, these knock-on effects of their initial drug use. We had people having seizures during withdrawals, and generally people said there's a real lack of support from services when I'm trying to come off benzos, and we'll look at that at the end of this session today. And finally, we had overdoses and hospitalization. So 5 participants had been hospitalized after taking high doses of benzos, and some had actually mixed with alcohol. One person was actually in a coma for 2 months as a result. And that might sound quite surprising, because you might think, well, this is like all from a medication that's prescribed by GPs. And yes, it is to a degree. But we have to bear in mind, it's not so much what you're using, it's really about how you're using it and also where you're getting from that's so important. So the 3 most common things we're looking at here is people getting a drug and then mixing it in a way that actually really increased the risk. They were using alone or with strangers. So in other words, when they started acting out of character, there was no one there who was really looking after them. And the final thing here is potentially sourcing the drug from a dodgy supplier. And this is a recurring theme, particularly with prescribed medications, is that people can have this delusion that, or this misunderstanding that the drug they're using is safe because it looks legitimate. Often when I've supported people using prescribed medications, they'll say, well, I know it's fine, because I'll try and talk to them about contaminated drugs, and they'll say, no, it's definitely fine because it's in the right packaging and I've got it from a friend. And sometimes they'll say the friend's got a prescription. But the point is that do you know definitely where the friend got it from? Because the friend could have got it from someone like this. Now, this was a news article that came out, I think, there you go, in April 2026 by the BBC. They did some undercover filming in a newsagent which was selling, the headline drug here was cocaine, but while they were there, the person selling the cocaine also said, well, by the way, I've also got all these drugs as well. And as you can see, they're in the proper packaging. And they were saying they were given recommendations about why you should try these different pills. Now, I've circled one there, Pregabalin, because that's one of the ones we'll be looking at today in this session. But it just goes to show how this is available on the illicit market and how it looks like the genuine product. Sometimes it will be because these are diverted supplies from pharmaceutical firms, but often it isn't. Now, another place where people might get this drug, and often actually increasingly we're seeing this, is online. So online pharmacies. There's been a huge growth in online pharmacies over the last 10 to 20 years. So you would Google, I want to buy diazepam, and it would come up with a list of places where you could do that. Now, a lot of online pharmacies are legitimate, and you can tell that because you can check the GPHC number, which is where it's registered. And it has to be registered to be legitimate. And you'll usually find that on the About Us page. But if it isn't there, then it's probably not legitimate. Now, like I say, a lot of them actually aren't. There's been some research into this to say of 35,000 online pharmacies worldwide, they found that 95% of them were illegal. In the UK in 2024, brilliant, Ash is on form today, brilliant. Ash has also checked this train. I should say thank you to Ash from the Daniel Spargo Mad Foundation. She's helped with making sure this is accurate. Also, in the UK, 2024, they looked at 116 online pharmacies. They found 55 of them were illegal. And by illegal, it means they were selling a product without necessarily sticking to the regulations to make sure it's safe to prescribe. And the product maybe was the wrong dosage or the wrong product entirely. But that might be misleading, because you might go online and think, well, I'm buying a product that's genuine pharmaceutical, a genuine pharmaceutical that's been made by a pharmaceutical firm, because that's what it looks like. But the reality is that sometimes they're actually manufactured in warehouses with pill presses like this by organised crime groups. Now, this is a pill press that you can see, which was seized by Northumbria Police in 2024. And not only did they get the pill press, they found large quantities of bromazepam there, which is a benzodiazepine, blister packs, and the packaging to make the product look genuine. So if you got that product, you would probably think it was a genuine thing, but actually it really wasn't. And this gets us to here about what the risk is. So this is the story of Kate Corrigan. She had become dependent on pain medication prescribed by her GP, in this case the Z drug, for chronic neck pain. Now, in response, the GP ended the prescription, and importantly, they did this without discussion with Katie. So the GP just went, oh, you're dependent to this now, I can't prescribe you, and it was ceased. Katie then didn't engage with the GP around this. She just basically went online and started sourcing the medications herself. And this ultimately led to an accidental fatal overdose because, you know, it's not necessarily the genuine product. Now, the BBC, as you'll see today, they like to try and check to see if they can buy these things online. When they looked at this, they were able to buy 1,600 various prescription-only pills by entering fake details into websites. So again, there's no one's really necessarily checking that this is a genuine. The person has the genuine needs and actually is prescribing when they shouldn't be. Now, it's important to point out people may be drawn to using these websites for convenience or to avoid the embarrassment of seeking help from a GP or to avoid the fact they don't have a prescription. So we have seen a big increase in people accessing drugs this way, and that might be why we're seeing these huge increases in death rates related to these drugs. You can see benzodiazepine deaths have almost doubled in the last 10 years. And death related to Zopiclone and Zopidem have also doubled, in fact, over doubled in the last 10 years. So we have really quite high numbers of people suffering very, very serious harm as a result of these medications, again, because of the way they're being accessed or used. But if you want to see a really big increase, and this is big already, take a look at Pregabalins. So Pregabalin's death rates have actually doubled, not in 10 years, but within 4 years from 2018 to 2022. And again, importantly, we should point out 90% of these deaths involved another substance, so people had mixed the drug with something else. And this continues to rise today. Now, again, the BBC did some work here to try and find pregabalins for sale illicitly, and they didn't have to work too hard. There's the text messages where they arranged this. They found it was very easy to buy pregabalins on the illicit market. Now, pregabalin is quite a new drug. It came to the market in 2004. It's generally prescribed for nerve pain, epilepsy, and anxiety. And it is being more widely prescribed by medical professionals, but it's also become much more widely available on the illicit market. So a bit like benzos and Z drugs, this has become quite a big market sector on the for illegal drug use. It is safe when it's been prescribed, but if you take it against that advice, you're taking a much higher dose or you're mixing it with other substances, then it does become potentially really harmful. And that's where I'm going to hand over to Craig to talk us through about what's happening in North Yorkshire and what we're seeing and why we've chosen this topic for today. So Craig, can I hand over to you to take us through the next part of the session?
You can. Unfortunately, my camera has decided not to work now. We're having a bout of tech issues today, but hopefully you can hear me anyway.
Yeah.
Brill, did you embed my slides into your,
There you go. Yeah.
Perfect. All right, that's great. You can click it on one, because I think I've gone posh with the text.
You've got carried away with the design, haven't you?
Yeah.
Yeah.
Oh no,
Okay.
it's not. It hasn't jumped. Right. Sorry. Go back then. I thought that there should be some text that jumps up there, but anyway. But what it was saying ultimately in that text is prescription drugs, or are they? And I think Matt's already kind of jumped on that point in terms of different types of prescription medications. Yes, absolutely, there is obviously prescribed medications which will benefit people in lots of different ways, but the market there in terms of illicit and fake benzodiazepines and just generally different types of tablets, Z drugs, synthetic benzos is just ever increasing. It's phenomenal, to be honest, and it's very hard really to kind of keep up with in terms of what tablets are in circulation, what are they, and what are the risks. And one of the ways that we do that in North Yorkshire, obviously we have our emerging drug trends meeting, which is fantastic in terms of sharing that knowledge. But we also have our drug analysis project, NYDAP, which allows us to take any substances that are found at scenes of harm, whether that be a death or a non-fatal overdose. And sometimes as well, if police have seized some illicit drugs and they're not going down an evidential route, then we can send them to York University for rapid testing to try and understand what is in circulation and what the risks are to people. So you may have seen only recently we actually did have a drug alert out across the whole of North Yorkshire, and that was due to a synthetic benzo called atazolam, and that was actually in the heroin supply. Now, atazolam is really potent, so it's about 10 times stronger than diazepam. So to have that in the heroin supply itself is a real kind of risk. But you can see here, we've got a variety of different, and I could have probably done about 5 different slides, to be honest, with all the different things that we've tested over the course of this year. But we'll go through them. And one of them is Pregabalin, that's the top left. And so they're the red and white capsules. Like Matt's kind of highlighted in terms of the prevalence of Pregabalin is just going up. Part of that was because we've talked about obviously diazepam being heavily prescribed historically. There was a big movement then really across the health sector and certainly within GP practices to get people off diazepam. And one of the things that was kind of just introduced at that time was Pregabalin, and it was kind of being kind of touted really as the answer because it was not dangerous and wouldn't be necessarily giving people side effects. So you did get quite a lot of natural migration from people that were potentially prescribed benzodiazepines, and especially people that were maybe also using illicit drugs, where GPs were kind of seen as really dangerous to kind of prescribe benzodiazepines if they were using illicit drugs. Then Pregabalin then became the kind of safer option. So historically, there is a lot of people that are prescribed Pregabalin, but also Pregabalin can be prescribed for various different things, whether that be anxiety as well as nerve pain. So I'll just admitting that person in. So we are seeing huge amounts of Pregabalin coming into North Yorkshire and on the country, and a lot of that is coming from India, online markets, like Mark says. We have tested probably over 30 now Pregabalin capsules. So you can see the ones in the picture here. They've got signature written on them, but we have other ones as well, and they all tend to come from India, and they all are Pregabalin. And they all have tested in terms of the actual dosage that it says. So we haven't found any illicit, and that's the same as nationally, really. We're not seeing Pregabalin really being contaminated. The issue is that sometimes the kind of Pregabalin that comes into the country is at a higher dose than what can be prescribed in in the UK. So the maximum dose in the UK generally is 300 milligrams, whereas we often see 450 milligram capsules coming into the country. So I'll talk a bit more about pregabalin in a second, but then we've got some other tablets there. So these were blue tablets. These are linked to 4 people ending up in hospital after taking them and overdosing. When we tested these were fenazolam. Now, fenazolam itself is something that we haven't really seen in North Yorkshire, and actually looking across the country, it's not been seen particularly that much either. So that was something that we kind of put an alert out about. Again, another potent synthetic benzo. We've got these kind of capsules there as well. So these were described as wobbly eggs, and we've been seeing these kind of cause quite a lot of overdoses, non-fatal overdoses in the Teesside area, and we actually had a non-fatal overdose where police administered naloxone and somebody was delivering CPR to somebody on the border of Teesside in North Yorkshire, and after testing these actually came back as meclomazepam, which again was not something that we've kind of seen. And then just the last kind of tablet there you'll see was ethylbromazole. So we've heard of bromazole. Matt's mentioned that already. That's been something that we've been seeing certainly for the last 2 to 3 years. It's been the most prevalent illicit benzodiazepine that we've seen in the market. Because China's now banned that, we've got the whack-a-mole effect of the people kind of manufacturing these has tweaked the compound, so we've now got ethylbromazole, which at this time we don't really know and understand whether that is stronger than bromazole or not, but it's certainly likely to be the same strength. And all these drugs cause significant harm, especially when people are taking them at large quantities, but also, like Matt said, alongside other drugs. And then the last tablet here, which you can see, which obviously looks like Xanax because it's got it printed on. Now, this was the tablet that was linked, sadly, to 2 deaths back in 25. And on testing of this tablet, it showed the presence of nitazene, so N-paralindo-etonitazene, which was 500 times stronger than heroin. So really significant. And this was being manufactured in Scarborough. So pill presses were found not to the scale that Matt showed you for sure, not as large a scale as that, but the thousands of these tablets were actually recovered from the Scarborough area. So just kind of gives you a little bit, like I said, I probably could have put 3 slides together around all the different ones, but just gives you a bit of a taste of what we're constantly trying to monitor. You move us on, Matt?
Yep.
So in terms of coronial data, so this is something that we kind of struggle really in terms of getting access to this data. Well, we won't go into that because that's a different story and we'll be here for a couple of hours explaining that one, but we have with our police colleagues managed to get a dashboard kind of created. We're waiting for the next batch of data to update, but the data here kind of takes us from the 1st of the 6th 21 until kind of January 24, and we're going to kind of focus in on 2 areas really. So drugs that were highlighted in post-mortem, sorry, get my teeth back in, and then kind of drugs that actually contributed to death. So you click us onto the next slide, Matt, we'll be able to zoom into that. So this is kind of really, I guess, for us in terms of public health, and from a drug service perspective, we didn't really understand what was causing harm because we didn't have the coronial data. But now we've got access to that, albeit not particularly fast, but we're getting access to it. It chucked out some really kind of worrying information. So you can see here when we're talking about pregabalin, so these are all on the left-hand side. These are the drugs that were basically found in post-mortem drug-related deaths. So you can see that pregabalin was found in 52 of those deaths, so equal to kind of heroin and morphine. But then when you go across in terms of contributed to death, pregabalin was actually 2nd. So this was something that we weren't kind of aware of. We knew people were taking pregabalin and we were starting to see non-fatal overdoses, but we didn't really understand that it had been linked to so many deaths. So as a result of that, you can move us on to the next slide, Matt. As a result of that, we then started to do some task and finish work, and really trying to actually understand what the problem was and where it was coming from, and what we needed to do about it. So when we're thinking, firstly, it was about, well, from a police perspective, it wasn't on police's radar at all in terms of pregabalin. You know, from a county lines perspective, people aren't selling pregabalin. It's often crack cocaine and heroin, and that's often where police focus their efforts. However, what we were saying, well, actually, look, we've got evidence here that pregabalin is actually causing significant harm in North Yorkshire. So, you know, what are we going to do about this? And the police's kind of answer to that was, well, what do we know about it? You know, how much of this is prescribed? How much is this people selling their prescriptions? You know, do we know if this is illicit pregabalin? So we went to the drug service and we had conversations with the drug service in terms of, well, do we understand within the population of people that are using these services, you know, do we understand how many people are taking pregabalin? And at the time they didn't really, because they weren't testing for pregabalin. It's not something that's generally built into the drug screens that are used in drug services. So we said, well, we need to change that. And we were able to kind of buy some bespoke pregabalin and gabapentin strips, and as a drug service started rapidly testing kind of people who certainly were using opiates to see whether or not they were also using pregabalin. And within the first 3 months we had over 200 detections of people that were positive for pregabalin that previously we didn't know, because people weren't forthcoming with that information. So from that, we knew we had to kind of put some resources together. We needed to give people the understanding of the risks around pregabalin. Now, there's some new research has also come out recently around pregabalin, and that is that pregabalin reduces the tolerance of people who are using opiates. So if people are using opiates and they're also using pregabalin, then the pregabalin can reduce that person's tolerance to opiates. Now, that's not really kind of commonly known, and we did some scoping around that across our GPs, and that wasn't really understood at all, and people who were using pregabalin didn't really understand that risk either. So that was one of, I guess, the risk factors in terms of increasing for overdose, is that, you know, if they're using pregabalin, it's reducing their opiate tolerance, and while they're polydrug using, they're more at risk. So with that, we obviously put some resources also on Drink Drug Hub, but we also lobbied to the government, to the Office for Health Improvement and Disparities, to say, look, this is a real issue. You know, we've seen harm in North Yorkshire. We've got all this evidence here. And I'm not saying that just because of that, they decided to ask the Advisory Council for Misuse of Drugs to do a kind of a review around prescription drugs, but they did then put out a call for action, which we obviously responded to as a partnership alongside GPs, the police, and we put loads of information and research across to them to say, yeah, this is a massive issue. And as a result of that, which we were really kind of pleased about, the MHRA reviewed the guidance that was available around pregabalin, benzos and Z drugs, and they kind of reissued guidance around that to all prescribers and GPs around the risks. So we're really pleased about that, and that's really kind of put it back on the cards that pregabalin is a risk. From a local perspective, what we see, I guess, with pregabalin is that people tend to take large quantities, and what I'm talking about is where people are taking over 1,000 milligrams. And what we've seen is using that kind of dosage alongside other drugs is often where people tend to start either overdosing or also having seizures. And we've seen that a lot, certainly in Scarborough, where we've seen a real influx of pregabalin coming through from the internet, the fast parcels, the Indian brand. And we've seen lots of non-fatal overdoses where police have responded and administered naloxone, which hasn't been effective because it's not an opiate. And people have then kind of come around and said, yeah, I've been taking pregabalin and alcohol mainly. But over 1,000 milligrams, we've really kind of seen people having that higher risk of overdose and that dependency level. And I think what was interesting when we did the review within Horizons, we found that some people were taking close to 2,000 milligrams a day, and they really didn't understand also about withdrawals. So that's why the fact sheet that we now hand out is really helpful for people. Okay, Matt.
Okay. Cheers, Craig. Thank you for taking us through that. And I've seen Ash has been putting some great stuff in the chat as well for more information about pregabalins and other tips and advice there. So to finish off the session, we'll look at how people can get help and support if they're struggling with these drugs. So firstly, people may go to their GPs if they are finding they're dependent on these medications. Now, if that happens, if they get support from the GP, the GP may be able to take them through a reduction plan if the patient feels able to engage in that. And there is some really good guidance around how to do that. We've got the Ashton manual, which was created by Dr. Heather Ashton at Newcastle University. It's quite old. It was last reviewed in 2002, but it still is really commonly referenced in terms of providing dosages and timescales for withdrawing from various benzodiazepines and also Z drugs as well. But again, that depends on whether a patient feels in a place where they can come off medication in that way, but that is an option for them. Some researchers suggest that if someone feels like they can't come off medication in that way, like they still need to take it, then sometimes it may be the lesser of two evils to maintain them on a dosage of prescribed medication instead of stopping it and forcing them onto the illicit market. In other words, it's better to take a known drug rather than access the illicit market. At the same time, though, there's also some research that tells us that when we do this, patients will sometimes say, well, yeah, then I use up all the prescribed medication first and then move on to the illicit market anyway. So there's no really straightforward answer here, but there is clear guidance in terms of being able to withdraw and do a reduction plan. Timescales for this vary, but can be up to 6 months from the guidance that I've read on this. Now, for people who are using illicit diazepam or illicit drugs, they come to North Yorkshire Horizons, and if it's illicit diazepam, they can prescribe up to 30 milligrams daily to immediately commence a reduction plan. So the idea is immediately start reducing off this with a safe drug that is being prescribed. They can't prescribe Pregabalin or Zopiclone. Now, researchers do recognise that clearer guidance is needed to support both prescribers and patients. This is a bit of a grey area at the moment. And you can see at the bottom a quote from a research from 2025 saying, well, we're hoping that in telling the stories of people who go through this, that we might be able to change the guidance and services that's being provided. Basically, they were saying we need more flexibility in our approach on a national guidance level. Finally, though, there is guidance on staying safe. So anyone who's using these drugs, whether they're looking to quit or not, they do need support to stay safe. The first one would be education. So understanding that these drugs aren't necessarily safe, even if they're coming in legitimate packaging, and even if they have been prescribed more widely by GPs, the product you're getting illicitly might not be the genuine thing. And also, how do you know how to take it if it's not been prescribed? So how do you get the dose right? And what about mixing it? So people need to be aware of how to try and stay safe when they're choosing to take these drugs. They need to be aware about dependency. A lot of people don't seem to have that awareness that by taking these regularly, they can become dependent. So they need to monitor how much they use and how often, and have an awareness of what withdrawal looks like and how to get help if they experience that. A really big piece of advice is trying to avoid mixing these drugs. That's advice for any drug use, but particularly with these ones today, because that seems to be a big contributor to harm. If you are going to mix, if you're going to decide to anyway, then try and reduce the dosage considerably. As always, we recommend low and slow. That means you take a small amount of the drug and you wait until you see how it feels before taking more. If it doesn't seem to have the effect that you expected, then just safely dispose of the drug and don't take more, because it's clearly not what you thought. If possible, do test your drugs. You can send them off to a Wedinos. There's a link there, and I will send these slides out. So you can send them off and get them tested to see what's actually in the drug. And if you're at festivals, often the loop are there and they can offer testing at festivals as well. And finally, do pass on advice and look out for friends. As we've seen already, sometimes when you're taking these drugs, you might behave out of character. You might behave differently to how you would do ordinarily. You may be trying to take more drugs even though you're intoxicated already. So a big thing is trying to keep each other safe and passing on this advice. Now we've got a little bit of time at the end here for questions if anyone has any. We're until 12. Craig and I will probably be able to stay around after 12 if people do have those questions and want to keep asking. We've got some time in hand. I've seen in the chat, we've got some things in the chat, which I think we've already responded to. And again, a big thanks to Asha for putting those links in and also checking this training through before we delivered it today. I'll come off this then. I'm glad we delivered that. Just honestly, 3 minutes before this session was going to start, all the technical stuff was going wrong. So there we go. Hopefully everyone's still there. I hope you are. So does anyone have any questions you'd like answering at the end of the session? You can put it in the chat or you can unmute and ask. And by the way, it's a good time to ask. You've got Craig here, and Craig knows an awful lot about this topic. So looks like maybe we don't have questions. Okay. Right, so if you don't, oh, okay. So Claire's asked, is mirtazapine included? That's one that you might be able to help with, Craig.
Is it included in terms of, it's certainly included in terms of harm. So I think it was on the slides that I showed in terms of the coronial data, mirtazapine was definitely in there. Is it one that we see kind of in the illicit kind of fold at the moment? It's probably not. I think ultimately there's other kind of benzos that are more popular in terms of using illicitly, and like Matt said, Zopiclone obviously is a Z drug as well. So it's not one that we see getting sold illicitly that much, but yes, it absolutely will contribute to one of the tablets that causes harm for sure.
Brilliant, thanks. Samantha's asked, if you are prescribed pregabalin, do you still need to be careful with alcohol consumption? I'm going to say yes, but Craig, do you have any more detail than that?
Yeah, I mean, yeah, it is yes. It ultimately depends on how much the person's prescribed and to kind of, I guess, also the levels of alcohol that they're consuming. But yes, if they are, certainly drinking problematically, then it's worth a conversation with the GP. Does the GP know that? And I'm sure, yes, it would be then a conversation between the GP and the person to look at that and make sure it's safe.
Perfect. Greg's asked if we've got an easy guide of products to look out for when they're doing enforcement visits. I'm not sure what guide that would look like. Sorry, go on. Do you have an answer there, Craig?
I think the crew link, which is obviously being put in the chat, which is also on Drink Drug Hub as well around benzos, is really useful. So obviously that does list the different types of benzos and also the kind of potency. Unfortunately, to be honest, from a police perspective, when we review samples in our weekly meeting, the most dangerous ones, or the ones that are more likely to be contaminated, are generally the ones that are loose. They're not in any blister pack. They don't even sometimes have markings on them. So it's very hard for police, even at the scene, to know what they are. So the guide on crew is probably a good one, just in terms of people that are on prescribed medications. But often it's the ones that aren't in blister packs that the ones we're probably wanting to test.
Yeah, and just to add to that, if you're on a visit and you do, one of the things to look out for is how are people storing these medications, particularly we have young people around in houses. How can we make sure that people aren't picking up and taking these? Like I say, young people potentially accessing them because they're in the house is another thing to bear in mind, and again is a really big risk factor.
I think the main thing that catches people out, and what I would say is that when from reviewing deaths for the last 5 years in North Yorkshire, I'm a big believer that if we didn't have illicit benzo use, then we'd see such a reduction in deaths, because although you've shown the data from kind of benzo deaths, and that's obviously going up, what we don't see in there is where people have been, have probably used a poly drug use mixture, and that will include potentially opiates. And often the opiate might be the one that's been named as the drug that's caused the death, but actually it's probably the benzo that's taken the person over that tolerance level, because they've taken them in such large quantities, and because of the half-life, so in terms of how long it takes to get into the system and how long they then lasts in the system, is often what catches people out and causes that kind of accidental non-fatal overdose or accidental fatal overdose. So we've evidenced that in Scarborough last year, where I showed you the red Xanax tablet, and from the police action around that and the removal of that person in the Scarborough area, and we haven't really up until recently seen any illicit benzos, and we saw a 44% reduction in deaths. So we know that absolutely contributes massively if there isn't benzos in the community.
Perfect. Okay. I don't think we've got. Okay, I don't think we've got any of the questions there. I think Susan's just saying illicit drugs would be helpful. So I think if that's everything, if everyone's asked the questions they want to ask, we can finish the session. I'll just finish the recording. There we go.